All right, so tonight's topic is going to be shock review. So we're going to kind of go over the different types of shock that are there, different treatment plans, and I'm going to hit a little bit heavier on the septic shock and sepsis recognition when we get to that point. All right, so shock is hypoperfusion. So inadequate state of tissue perfusion or cellular perfusion is shock. So any compromise in the perfusion can lead to cellular injury or death. In the early stages, the body attempts to maintain homeostasis. And that's going to be like our compensated or decompensated irreversible types of shocks we can come in contact with. And really the big thing is recognizing early onset of these patients going into shock. So seeing that tachypnea and that tachycardia like prior to them becoming hypotensive, looking at the mechanism of injury, palpating the abdomen, palpating the body, looking for different types of injury patterns that could be leading towards that shock, where we can start treating it early. Because the more shock progresses, the harder it is to reverse that effect. So we need to catch this kind of stuff early in the act, whether it be like a neurogenic, hypovolemic, distributed types of shocks, things like that. So diffusion is a passive process in which the molecules move away from an area with higher concentration of molecules to an area of lower concentration. So think of diffusion being like a gas, there's molecules that are there. This is how oxygen and carbon dioxide cross the walls of the alveoli. It's kind of like how that works. So the majority of oxygen is carried to the tissues, is attached to hemoglobin. So hemoglobin transports through the body, it transports 4 parts oxygen. And what's happening is as it's transporting, it drops one off, comes back around, picks up a third. Because you never want to have that car empty, right? It's never going to be a good party if you don't have multiple people in your vehicle. So think of that hemoglobin as your vehicle. So as one gets out, a new one comes back on, and one gets out, a new one comes back on. So the hemoglobin are still always transporting that oxygen or that party around the system. And that's kind of how that's working. So if we have a patient, like for example, with our pathophysiology here, if we have a patient that is hypovolemic and they're bleeding out, we're losing those platelets, the hemoglobin, and all that kind of stuff, then we don't have that ability to transport as many oxygen particles throughout the body, right? So we got to make sure that we have blood to be able to make sure that is transporting appropriately with all the hemoglobin that's there. So the carbon dioxide can be transported in the blood from tissues back to the lungs in 3 different ways. All right. One way is dissolved in plasma. The second way is combined with water in the form of bicarbonate. And the third is attaching to the hemoglobin. So carbon dioxide, remember, is a waste product released from cells, which can combine with water in the bloodstream to form a bicarbonate, your bicarb. Another name would be HCO3. Once it reaches the lungs, the bicarbonate then breaks down into carbon dioxide and water, and the carbon dioxide is now exhaled. So I harp, like in every class I teach, we always mention the word end-tidal CO2. Why is that so important? Why do we need to monitor that? This is why, right? This is why we monitor those end-tidal CO2, because we're looking at adequate perfusion, looking at those numbers between 35 and 45, anything being high in the end-tidal sense being acidotic, and anything being low end-tidal would be considered alkalotic. So we really need to look at the end-tidal readings to make sure that we're hitting that 35 to 45 range, or absolute being 40. Okay, that's why it's so important to measure end-tidal CO2 readings with basically almost all our patients that we come in contact with, but especially your respiratories, your cardiacs, but your traumas. We need to make sure we're monitoring end-tidal during trauma. So in cases of poor perfusion or shock, the transportation of carbon dioxide out of the tissues will become impaired, resulting in a dangerous buildup of waste products, which may cause that cellular damage. So remember that shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. So to protect vital organs, the body directs blood flow from the organs that are more tolerant of low flow, such as the skin, intestines, to organs that cannot tolerate low blood flow, such as the heart, brain, and lungs. So early recognition of the signs and symptoms of shock can definitely save lives. Remember that shock is a life-threatening condition. It requires immediate recognition and rapid treatment, right? Fluid replenishment. The big thing, though, is if they're in shock and they're becoming hypovolemic, is whether or not it be, let's say it's a trauma, they need blood products. Who provides blood products? Critical care teams. They provide blood products for administration. Flights. Calling helicopters early for patients that are significant for the need of blood products, being like a traumatic injury, motor vehicle accident with entrapment, significant motorcycle accidents, things like that, where there's definitely going to be internal injury. But you can also have hypovolemia, not just from blood loss, but just from fluid loss. Think about your patients that are really sick in regards to vomiting, diarrhea, patients that are very hyperthermic, patients that need that fluid replenishment. So on an ALS side of things, for intermediates or paramedics that could be in the room here, or I say intermediate advanced EMTs, sorry, I'm old school. We look at what kind of fluid we can replenish these patients with. Now, in the state of South Carolina, we are allowed to carry two types of fluids, one being lactated ringers, the other one being sodium chloride. The reason why I don't use the name normal saline, there's nothing normal about normal saline. That's why we call it sodium chloride is 0.9%. If you look at our body's pH scale, right, our pH scale being obviously, 1 to 14, 7 being normal, right? Anything low is acidotic, anything high is alkalotic. Our body likes running a slight bit alkalotic, right? So our normal range is 7.35 to 7.45, absolute being 7.40. We want to make sure to maintain homeostasis that our N titles are within normal range, that our bicarbonates between 22 and 26 being in normal range, which is no way for us to measure that in the back of an ambulance for 911 purposes. And we want to make sure our pH kind of sits between 7.35 and 7.45. So why am I bringing up all these numbers? Why is this important to us to have an understanding of what this stuff is? Well, our not so normal saline that we do carry on the ambulance, sodium chloride, has a pH of 5.5. That's low. So if you have an already acidotic patient and we're giving a more acidic fluid, it's not going to change what we're looking to change, right? To meet that homeostasis, that hemodynamic stability. Lactated ringers, LR, which has like sodium, potassium, chloride, magnesium, all these different electrolytes these patients need to survive, has a pH of 6.5, which is definitely closer to what we're trying to administer or trying to reach with our goal. On top of that, blood products and lactated ringers pH are very close, and LR follows blood better than it does with saline following behind it. So I know that went a little more in depth, but have an understanding. This is why we give certain fluids to certain patients, depending on what they need, right? So if I have a patient who's had bouts of diarrhea, bouts of vomiting, they're very sick, their blood pressures are low, oh my God, they're in shock, right? We can treat that as long as there's no internal bleeding with lactated ringers, and they're going to replenish those electrolytes. It's like high-test Gatorade being administered through an IV. So that's kind of what we're looking to do. So the cardiovascular system consists of three parts. There's a heart, there's blood vessels, and there's blood. Heart being the pump, the vessels being the container, and the blood being the content inside of it. As you can see on this figure here, the cardiovascular system consists of the three parts that are listed. The heart, the pump with the heart, with the container, which are the vessels, and then the contents, which are the blood. So the blood carries the oxygen and nutrients through the vessels to the capillary beds. where they diffuse into the tissue and exchange waste products and diffuse into the bloodstream, as you're seeing here. So with that being said, we have to make sure not only are we getting the patient the proper amount of fluid for shock, we also need to be oxygenating our patient to help perfuse the tissues. And if we're not perfusing the tissues and the patient becomes hypoxemic, then just giving fluid is not going to fix the problem that's currently there, right? So we got to make sure that we have the fill container. So we have to have good preload, fill the container to be able to pump. We have to have oxygen to kind of flood the system, but we need to provide more oxygen to get through the system for better perfusion, right? And we got to make sure that we're not vasoconstricting too much to the point where the vessels can't get the nutrients that are needed. So there's a lot of things that play into this. We talked about shock as well, where the patient becomes hypovolemic. Well, I keep using hypovolemic for this point in time, but now you start seeing that pale, that diaphoresis, pale, sweaty skin. Those are patients that are going into shock. Why? Because the capillary beds and that external vasculature is starting to shut down to keep the main organs that require the higher blood flow adequate, right? So we start shunting blood away from the extremities to the core. And if we're doing that, yes, the body is still trying to stay alive, but we need to make sure it doesn't continue down the direction of decompensated shock, where at that point we start seeing the hypotension going to irreversible, where the patient is going to die. There's no way to change that. So we need to catch it early. So if we're looking for a patient who has hypotension as an early sign and you have it, that's a very late sign. We should not even be thinking about hypotension, looking for early signs of shock. We need to look for that inadequate tissue perfusion, that pale diaphoresis skin, tachycardia, and tachypnea are the other two things we look for, right? If we start seeing that, there's something wrong. We got to figure out what type of shock they potentially could be in. Right? So this is what they call the perfusion triangle. We have the heart, which is the pump function. So damage to the heart by disease or injury decreases the ability of the heart to properly function as a pump. Therefore, it cannot move enough blood through the body to support perfusion, like cardiogenic shock, a myocardial infarction, MI, heart attack, STEMI, things like that. Those things can make the pump not function appropriately, right? If we have that, they need to have something other than fluids. They need to have something to pump, but they need something else to kind of assist, okay? And those patients that are in those cardiogenic shocks, they're going to get, obviously, if they're going to the cath lab, to a PCI center, and they find they're in significant cardiogenic shock, and they have, let's say, left ventricular issues, they may put in a balloon pump or an Impella to help pump the heart because their ejection fraction is so low that the heart can no longer pump effectively, right? Or they may need some support like a vasopressor, like dobutamine, dopamine, levofed, things like that. Phenylephrine is another one, true alpha pressor, where they can help pump that heart and help that pump function, right? So blood vessels, which is the container function, if all blood vessels dilate rapidly, the normal amount of blood volume is not enough to fill the system and provide adequate perfusion to the body. One of the types of shocks that we talk about is going to be our septic shock, right? So our septic shock is a widespread full body vasodilation along with bacteria in the system, bacteremia, which then puts the patient into a systemic inflammatory response syndrome, which then turns into sepsis, into severe sepsis, into septic shock, and then MODS, which is multiple organ dysfunction. And then the patient can die. They start developing DIC, and then things can go pretty bad from there. So as you can see, there's a significant progression if we cannot catch this stuff early in the field. Like I said, I'm going to hit harder on sepsis than I am any of the other shocks because sepsis is one of the most missed things by EMS providers. The simple, subtle signs that are there on part of your BLS assessment, I can say this patient is probably septic. Doesn't have to be septic shock. They could just be septic or the early stage of sepsis, where we can start treatments in the field pretty quickly. All right. So blood pressure is the pressure of blood within the vessels at any moment in time. We have two, right? We have systolic and diastolic. Systolic pressure is the peak arterial pressure or pressure generated every time the heart contracts. The heart is contracting, right? Causing blood to flow. So what will happen is your atria will contract and your ventricles will contract. Atria, ventricle. This allows the four chambers of the heart to be filled and pump blood through the body. So looking at an EKG, I'm going to try my best to draw this on the screen. So here is we have our isoelectric line. We have our P wave here. We have a QRS. Don't mind how wide that is. I can't draw very well. And we have our T wave. Okay. Why is this important? Well, I'm going to cover a little bit of ALS stuff here. So when you guys look at a cardiac monitor, you go, well, that's what's actually going on. We have something called depolarization and repolarization. This is how the body, sorry to rephrase that, this is how the heart pumps, right? Repolarization is filling, depolarization is pushing fluid out, okay? Your P wave, which is your first wave here, that wave is atrial depolarization. So that's your atria electrically firing, pushing that blood to the ventricles, right and left ventricle. Remember that looking at a heart, let's say I'm going to draw a big square as our heart today, we're square-hearted, right? I do this here. Draw a line down the middle. Let's say this is the left side. This is the right side. Let's say this is the left side, okay? This side here has no oxygen. It's deoxygenated blood. This side of the heart has oxygen. So it has to go from here through the lungs to the left side. So right side, lungs, left side. Remember that there are four chambers, right? Right atrium, right ventricle, left atrium, left ventricle, right? So now that you see this here, I'll go back to the EKG. So as the P wave goes, that's atrial depolarization, which means that this is pushing in a downward direction to the ventricles. This QRS complex that you're seeing here is ventricular depolarization. So when you feel for your own pulse and you feel that beat, that is a QRS complex, and that is blood being pushed from the right side into the lungs, and the left side through the aorta back down. So remember, we have our ascending aortic arch, descending aorta. Then it supplies the renal arteries to the kidneys, and then it supplies the femoral arteries to the lower extremities. Okay, and then up top, subclavian, carotid, things like that up here that go to the brain, into the heart. Not the heart, into the extremities, like upper extremities being here. Okay, so knowing how the heart functions and how this is working, right? So remember, QRS complex, ventricular depolarization, pushing blood out. Underneath all of this, your atria is repolarizing, which means now it's filling back up again. And then your T wave is ventricular repolarization. So think of it as squeeze, top, bottom, top, bottom, top, bottom. That's your systolic, diastolic pressures, looking at how the heart contracts. Diastolic pressure is pressure maintained within the arteries while the heart rests between the heartbeats. So during that repolarization phase, okay, that's how much pressure is still in there. And we want to have it right around 70 to 80, okay? We really want to get higher than 110 for a diastolic pressure, okay? We also want to know what the systolic pressure is. But the big thing behind all this stuff I'm talking about, okay, is you need to know what your mean arterial pressure is. And that's what we look for, especially in a septic shock, your MAP, your hypovolemic shock, all these different shocks we talk about. We want to maintain that map of around 65 or higher. Well, how do you get your map? Put them on a cardiac monitor. You do an auto BP, tells you what your map is on the screen, right? But your cardiac monitor, you didn't charge it, the battery dies. And we want to know what our map is. Does anybody know the equation on how to figure out what your mean arterial pressure is? Hearing nothing, you guys can type it in the chat if you want to. But I will go over this with you guys as well. So what we're going to do is we're going to take, I'm going to put D here. Okay. Diastolic times 2 plus systolic equals whatever number you get. We're going to divide that by 3, and that equals your map. Okay. So if you have a blood pressure, for example, let's say you have a blood pressure of 80/42. Okay. 80/42. So what you're going to do is you're going to take 42, multiply that by 2, okay, plus 80 equals 164. We're going to divide that by 3 because you have a map of 54. Okay. That's low, right? We want it to be higher than that. So we need to give them some more fluid or blood products to get that map back up to where it needs to be, above 65. Anything below 64, our body is not perfusing appropriately. So make sure that you guys understand this. This is important. We talk about blood pressures all the time. When we start talking about shock, we need to know what the mean arterial pressure is and make sure that it's greater than 64. Okay, 65. That's going to be our magic numbers you need to look for. In trauma patients, looking at a systolic versus diastolic, we really want to make sure we're hitting that number about 90 systolic, because if, let's say, there is a bleed somewhere going on, right? If we bring that blood pressure up too high, what does it do to the hole that's there somewhere internally? It makes it bigger. Therefore, we have more bleed. More bleeding is bad. So 90 systolic is a good number to look for. We also want to make sure our body's also perfusing. And if our map is below 64, we're not getting the perfusion that we need. All right, any questions on that at all?
I'm good here.
Okay. There we go. I hit the wrong button. All right, so pulse pressure is different. Is the difference between the systolic and diastolic. Systolic minus diastolic equals your pulse pressure. This signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 may be seen in patients in shock, right? So you take your systolic subtracted by your diastolic equals the pulse pressure, okay? So it has to be greater than 25. There are some things we look at. This is not a shock deal, but again, we look at those widening or narrowing pulse pressures. One of those, the widening one, is going to be your Cushing's triad for intracranial pressure, right? And the narrowing pulse pressures is one of the 3 things of your triad for Beck's, right? Which indicates cardiac tamponade. Okay, nothing we're going to talk about in this lecture here, but again, we look for those pulse pressures that are there. The blood flow through the capillary beds is regulated by the capillary sphincters, so circular muscular walls that constrict and dilate. These sphincters are under the control of the autonomic nervous system, right, which regulates involuntary functions such as sweating and digestion. Interesting to talk about digestion and things like that too. Capillary sphincters also respond to other stimuli such as heat, cold, the need for oxygen, and the need for waste removal. Right, so regulation of blood flow is determined by cellular needs. So for those of you that have worked 911, okay, or even in a facility, if you've got a patient that's in a shock, one of the first things they complain about is being nauseated, because one of the first organs to shut down is your stomach. So giving a patient Zofran for this, that's not really going to fix it. They need to be perfused. That's why their stomach is starting to shut down, because they're trying to shut down the organs that don't need all that blood flow to give it to the ones that need the blood flow, like the brain, the heart, the lungs, things like that. So therefore, they start shutting down organs that aren't needed, and your stomach is not really needed, right? They can go without having the stomach being present and functioning when you're in deep shock like that. Perfusion also requires adequate oxygen exchange in the lungs, right? So if they're not breathing adequately and they're breathing rapid and shallow, they're not getting that exchange that they need, right? They're breathing too fast, which makes them very alkalotic. Their end tidal is going to be coming down. Not good. Nutrients from the form of glucose in the blood and waste removal primarily through the lungs. That's that carbon dioxide exchange. So if you're breathing too fast, the faster you breathe, the lower the end tidal goes. The slower you breathe, the higher it goes, right? So we want to make sure we maintain that adequate perfusion level between 35 and 45, looking at our end tidal readings. The mechanisms are in place to help support the respiratory and cardiovascular system when the need for perfusion of vital organs are increased. This includes the autonomic nervous system and different hormones, right? The sympathetic side of the autonomic nervous system, which is responsible for the fight or flight response, will assume more control of the body's functions during a state of shock, right? That's when our norepinephrine starts to kick in, right? The norepi, which is our body's neurotransmitter for the autonomic or the sympathetic nervous system, that other side, the fight or flight, right? This response is by autonomic system nervous is by the autonomic nervous system caused by release of hormones such as epinephrine and norepi. Hormones cause an increase in heart rate and in the strength of the cardiac contractions as well as vasoconstriction in non-essential areas. Remember I mentioned before, we start shunting that blood, primarily in the skin and the gastrointestinal tract for peripheral vasoconstriction. So if our GI tract is shutting down, our stomach starts shutting down. That's what starts causing that nausea that I mentioned before. So this response causes all the signs and symptoms of shock in a patient. So they have increased nausea. We start seeing the heart rate going higher, that tachycardia. We start seeing them breathe faster because now they need more oxygen, right? That's that tachypnea. And yet their blood pressure is still normal, right? Because it's trying to stay in that compensated shock and saying, hey, please help me. You need to start treating this now. So don't miss those subtle signs that are there, those signs that you can see and say, man, this patient is going to go into shock. They're showing signs of early compensated shock here. Let's start giving them the treatments that they need. Oxygen, high flow non-rebreather. Even if their oxygen saturation is showing 99%, if you feel that they are in shock, non-rebreather, 15 liters a minute, get that oxygen flowing, get it done early, right? Free radicals are bad. We understand if we give too much oxygen, it can actually hurt somebody. But short term like this, it's not going to hurt them right off the bat. They need that oxygen. They need to push it through with the hemoglobin to start perfusing the body. Because as we're vasoconstricting, that's less blood flow going through. Next thing we got to worry about too is giving them those fluids or different therapies that they may need to help with that perfusion. And then you got to find out the underlying cause. What type of shock are they in and why are they in it? And how can we treat it in the field? Or do we need to give them a bolus of diesel, I meant to say, and get them to the hospital where they can go in for surgery, right? To actually get whatever is going wrong repaired, right? So causes of shock, there may be different types of shock that result from three basic causes. Either it's going to be a pump failure, okay? So pump failure would be like your cardiogenic shocks. Poor vessel function, right? So poor vessel function being like vasodilation, vasoconstriction. So like your anaphylactic shocks being your vasoconstrictors, or you have like giving a vasoconstrictor like epinephrine, I should have said, my apologies. Or we look at other shocks like septic shock, but those show the widespread vasodilation as well. So that's our poor vessel function. And obviously low fluid volume being like your hypovolemias, things like that, right? So those are three different ones that are there. So what you're seeing here illustrates the slideshow with three basic causes of shock and impaired perfusion. This is your pump failure, right? So this causes would be like heart attack, trauma to the heart, obstructive causes like large pulmonary embolus, things like that. You have the heart issues, that pump issue, right? A PE is very bad. It's a big clot somewhere in the lungs, not allowing blood to flow appropriately, and also reducing your gas exchanges and oxygen coming back in. With a patient that has a PE, if you're on end-tidal CO2 and their end-tidal CO2 norm readings are normal, what will happen is you'll start seeing a sudden decrease in end-tidal. Like, let's say the end-tidal is like 35, for example. You'll see a sudden decrease to like 15 to 18 with significant shortness of breath. That means that the clot moved into a spot in the lungs that's where it does not need to be. Right? They have to have a thrombectomy done at the hospital. There's only one true way to tell if someone's having a PE in the hospital, and that's a CT angiogram. So your CAT scans with a CT angiogram is done. If you're ALS, try to get an 18 gauge or better. In the AC is the best place to put it, because that's going to help with a CT angio. They can run a D-dimer check, but D-dimers are completely useless anyways, because that can be elevated for multiple different things. So the true diagnosis for PE is going to be your CTA. Low fluid volume, obviously caused to be trauma to the vessels or tissues, fluid loss from a GI tract like vomiting, diarrhea, and it can also lower the fluid component of the blood. Poor vessel function causes to be like infection. We talked about that septic infection, drug overdose like narcotics, spinal cord injuries, so your neurogenic shocks, and then also anaphylaxis. And as we can see here, going over the different shocks, pump failure, cardiogenic obstructive, like a tension pneumothorax. These are your obstructive shocks. Cardiac tamponade, pulmonary embolus, tension pneumothorax. Remember that your cardiac tamponade is going to be your Beck's, wrong button, is going to be your Beck's triad. There's three things in Beck's triad you need to be familiar with, right? This is the basic level knowledge. Number one is your narrowing pulse pressures, right? So your systolic and diastolic are very close together, okay? Like 90 over 85, 86, like close together. It's narrowing the pulse pressure being less than 25. The second thing on Beck's triad is going to be jugular vein distension, right? Why do we have jugular vein distension? Because we have a tamponade, so the heart's not able to pump, so it's backing up blood through the jugular veins, and you can see that distension of the neck, right? And the third thing is going to be is muffled heart tones. So if you listen to heart sounds, they're going to sound very muffled because there's a lot of fluid, right, around the heart. And what they're going to do for this is what they call a pericardial synthesis. Big long needle through the chest into the heart, pull the fluid out. Nothing we're going to be doing in the back of the ambulance, right? Pulmonary embolus obviously is a clot that's released into the lungs. And then tension pneumothorax is that collapsed lung. But remember, the tension part is we start seeing hemodynamic changes. You can have a pneumothorax and you can still be fine with it in the back of the ambulance, where they might not even get a decompression and they'll get a chest tube later at the hospital. But when you start seeing that tension kick in, that hemodynamic changes, like hypotension, severe shortness of breath, all this, those are the patients that are going to be darted. Those are the ones that get those chest decompressions. They're going to get the finger thoracostomies by flight or critical care ground, or they're going to get a chest tube, or they're going to get a chest tube placed in the hospital. Your poor vessel function, distributive shocks like septic. Talked about that widespread bacteremia already. The neurogenic, spinal, stuff like that. Psychogenic shock, obviously the anaphylaxis, your reactions, things like that. Again, anaphylactic shock, we need to make sure we're giving patients epi. Know your dosing. For epinephrine, 0.3 milligrams. For the EMTs and advanced EMTs. For medics, we can go to 0.5. But for EMTs in advance, it's 0.3 milligrams. So it'll be an intramuscular injection for the adult. It's going to be in the vastus lateralis muscle, which is also the lateral aspect of the thigh. Right. For pediatrics, 0.15. EpiPens work well, but if you have the ready check inject kits, you have to draw up your own. Your hypovolemic shocks are your hemorrhagic or non-hemorrhagic shocks. Obviously, hemorrhagic being bleeding, non-hemorrhagic, diarrhea, vomiting, dropping that blood pressure back down. So kind of went over the different causes of shock. All right. Any questions so far? Hearing nothing, we'll move forward. All right, so cardiogenic shock, which is caused by an inadequate function of the heart or pump failure. The major effect is backing of blood into the pulmonary vessels, resulting in buildup of the pulmonary fluid. And because of this, we started seeing pulmonary edema. Right? So if we start seeing pulmonary edema, how do we treat that? What do we do at the ENT level? What can we do? What do you carry on your ambulance to get to put on someone's face? Provide
CPAP.
CPAP. So continuous positive airway pressure CPAP is providing positive end expiratory pressure PEEP, right? To hopefully push that fluid out. Okay, we're going to push that fluid. Keep in mind, though, in cardiogenic shock, you may have hypotension, right? So when you start pushing fluid out and provide that barotrauma to the chest and the lungs, you can actually decrease the blood pressure even more, which is why you got to be very careful. Look at your blood pressure before you start applying CPAP to these patients, right? If they're hypotensive and they have pulmonary edema and they have pink frothy sputum coming out of the mouth, get ALS on board, preferably a service that has RSI is even better. These patients need to be intubated and the fluid needs to be pushed out via a ventilator. Is going to be the best option for these patients, right? Because we don't carry Lasix and things like that. But again, we also need to fix that pump issue, and we can do that is paramedic level care. That can definitely help with the vasopressors that can be administered, right? But again, you look for the pulmonary edema, listening to that fluid on both sides, right? Don't be fooled by a patient that say they have a high temperature and things like that. That it could be a pneumonia. Listen for those fluid on both sides of the lungs and listen to lungs very well. If you have a hard time with lung sounds, here's a great training tool. All right. Training tip number 1. Find a computer, get a stethoscope, find lung sounds on YouTube, whatever else you want to use. All right. Take the stethoscope and place it over the speaker and listen. Right? We can all hear it, right? I could play it right now for you on the computer, and you're going to be able to hear that. But can you hear it through a stethoscope? Because sometimes it changes that sound. So try that, right? Right. It's like a homework assignment. Find a computer, a stethoscope, listen to lung sounds. Or if you have a nursing home in town, go to the nursing home and say, hey, do you mind if I listen to lung sounds? I guarantee you'll hear every lung sound possible within that nursing home. Just go around and be friendly and listen to lungs. All right, so cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. So cardiac output is the volume of blood that the heart can pump per minute and is dependent upon several factors. Okay. The heart must have adequate strength, which is largely determined by the ability of the heart muscle to contract. That's your myocardial contractility. The heart must receive adequate blood to pump. That's your preload. The resistance to flow in the peripheral circulation must be appropriate. That's your afterload. Your preload goes into that right atrium. Okay. So if you have no fluid there to pump, it can't pump anything out. Right. So if you let's say you guys have your cardiac monitor in the truck, you go to respond to 911 call, patients complaining of chest pain, you throw them on the monitor, and it says acute MI, and it says inferior wall infarct. Okay. You guys obviously as EMTs cannot diagnose or interpret, I should say interpret, a 12 lead. But your printout tells you something. If you have significant ST elevation and 2-3 AVF, okay, that's your right coronary artery that has a significant blockage, which also means you're probably going to have, in conjunction with that, hypotension. Why are they hypotensive? Because the inferior wall of the heart also controls your preload. Okay, which then can turn into a cardiogenic issue and or pulmonary edema. A lot of things can happen with that. Okay, so yeah, am I going outside the realm of cardiogenic shock a little bit? Yes, but I wanted to explain that preload part of it. It's like giving somebody nitro that has low blood pressure. If there's no preload behind it, it's just going to take what's currently there, which is very minimal, and then you're going to vasodilate, and at that point in time, you've dumped their blood pressure. Right? But also resistance to the flow of peripheral circulation, that's your afterload part as well. So you have to have something to fill the pump, and then it has to be able to push back out again. So for those of you who are maybe firefighters, think of what happens when your tank runs out of water and what happens to your fire pump. It's called cavitation. It's the same thing going on. Your pump cavitates, it starts to collapse on itself, and then it fails. That's pretty much what's going on there. All right, obstructive shock is caused by a mechanical obstruction that prevents the adequate volume of blood from filling the heart chambers. The three most common examples are going to be your cardiac tamponade, your pulmonary embolus, or your tension pneumothorax, which you've already covered those in pretty much detail. Remember that your tamponades are going to be your Beck's triad, right? So a pericardial tamponade, right, is cardiac tamponade. It's a collection of fluid between the pericardial sac and the myocardium. It's called a pericardial effusion. If the effusion becomes large enough, it can prevent the ventricles from filling with blood, a condition called a cardiac tamponade. Right? We have so much fluid around that pericardial sac, it can't pump effectively. Caused by blunter penetrating trauma that causes hemorrhage around the heart. Signs and symptoms of cardiac tamponade are referred to as, again, Beck's triad. Right? So Beck's triad is the presence of jugular vein distension, muffled heart tones, and narrowing pulse pressures, where the systolic and diastolic blood pressures start to merge together. A tension pneumothorax is caused by damage to the lung tissue, where air normally held within the lung escapes into the chest cavity. The lung then collapses, and if the pneumothorax is left untreated, air will accumulate in the chest cavity and apply pressure to the organs, including the heart and brain vessels. Remember I mentioned before, we have that collapsed lung, we have that pneumothorax, and then we start pushing that tension to the chest, where that mediastinum is located in the chest, where their heart is located and all that, and it starts putting pressure on there and not allowing the heart to pump. Therefore, it becomes a tension pneumo. A PE, pulmonary embolus, is a blood clot that occurs in the pulmonary circulation that blocks the flow of blood through the pulmonary vessels. When a massive PE occurs, it can prevent blood flow from being pumped to the right side of the heart, to the left, resulting in a complete backup of blood in the right ventricles and leading to catastrophic obstructive shock and complete pump failure. Right? The worst pulmonary embolus you can get is something called a saddle PE. That's going to be one of the worst ones you can get, the PEs. Distributive shock results where the tissue is widespread dilation of the small arterioles, small venules, or both. The circulating blood volume pools in the expanded vascular beds and tissue perfusion decreases. Right? So let's talk about distributive shock here. Septic. The septic shock occurs as a result of severe infection, usually bacterial, in which toxins are generated by the bacteria or infected body tissue. Widespread dilation of vessels combined with plasma loss through the injured vessel walls result in shock. What's happening is that your walls of your vessels become very leaky. They start leaking, right? So now we're dilating, we're leaking, we're losing fluid, our pressures are dropping, our heart rate's going up. We may or may not have a fever. Most likely you'll have a high temp. Cold sepsis is even worse, right? So a lot of things are going on with this here. We got to catch this kind of stuff early. I'll get more into sepsis here in a second, right? Widespread dilation of the vessels, in combination with plasma loss through the injured vessel walls, result in shock. So what we need to do is figure out what is going on. What kind of stage of shock are they in, right? Or are they in systemic inflammatory response? So the way I look at it is this. Okay, we have 4 different sections we're looking at, right? 1, 2, 3, and 4. I'm not sure how much I'm going to write this, but I'm going to put, okay, this is SIRS up here, systemic inflammatory response syndrome. These are key indicators of things that could lead into sepsis. Heart rate of greater than 90 is one of them, right? End tidal, less than 32. Respiratory rate, greater than 24. Right? MAP of less than 64. A temperature, greater than 101.4 or less than 96.8. Okay, 101.4, 96.8. Right? Those are some of your indicators of potential systemic inflammatory response. If you have 2 or more that means the SIRS criteria. This right here, this next one here is sepsis. Okay. So we take 2 or more of the SIRS plus a known infection site or suspected infection site equals sepsis. Next step, severe sepsis. Severe sepsis is everything that you've seen here, right? Plus hypotension, HOTN, okay, makes it severe sepsis. We're going to treat this with 2 liters of lactated ringers, right? If there's no change in blood pressure after the 2 liters that have been administered to this patient, I'm not talking about a slow drip. It's wide open, pushing fluid in, right? And there's no change in blood pressure. Now they're in septic shock. To treat septic shock is paramedic level. They're going to have to give, I'm going to put a P here. They need vasopressors, and the vasopressor of choice is going to be norepinephrine or Levophed. Okay. That's kind of the progression of sepsis. We need to catch it in the field here. Right? We got to catch it in SIRS or that sepsis criteria. Once you've gone past this and you're into this side, right? This patient's becoming sick and very sick rapidly. These patients are going to receive up to maybe 8 liters of fluid in the emergency department, right? Because of that widespread vasodilation, the bacteremia, things like that. They're going to receive antibiotics. They're going to potentially get on pressors. And if it's really bad, they're going to get intubated. Why are they being intubated? Because they're going to put on a ventilator to help control the respiratory drive to help push off those acids that are there. Okay. If it progresses and keeps going more and more and more, all right, the next step from there is going to be something called MODS or MODS, right? So what is MODS? MODS is multiple organ dysfunction syndrome, where we start losing organs. They start shutting down. Our stomach, right? Our kidneys being another one. Right? If that progresses and potentially goes into DIC, DIC is disseminated intravascular coagulation, which basically means that you have clots everywhere throughout the body. Your bloodstream is throwing off clots. And that can cause limb amputations and things like that due to multiple clots that are going on. So your simple paper cut over here gets infected, not treated, turns into you losing a limb. A simple paper cut, right? Pretty crazy. Which is why septic shock or sepsis is so important to me that I've actually developed a full sepsis presentation that goes more in depth than this, because we need to recognize these patients in the field. We're missing it. A lot of providers miss it, and then the hospital doesn't pick up on it, and then it's too late because we're not calling in sepsis alerts to the hospital. They can start treating it. Before we get distributed, any questions on sepsis? Did you guys understand the things that I was saying on that? There was a lot there. All right, with nothing
Good on
being
this
said,
end.
what was
No, we're
that?
good on this end. I'm good
You're
on
good?
this end.
Perfect. Any questions, Grant, on your end?
None from us.
Okay. I just didn't want to go too much in depth on it, so you guys got lost. But all right, moving forward.
Quick, sorry.
Yeah.
You said you have a whole presentation on it. Is it on the website?
It might be, but I've updated it since then.
Okay.
So we'll end up doing a sepsis lecture at some point in time with this monthly stuff anyways.
Okay. Cool.
Yep.
Thank you.
You're welcome. All right, neurogenic shock. So usually the result of a high spinal cord injury, like up high. With spinal injuries as well, you need to understand your dermatomes. right? So a quick reference to kind of know like what dermatome is being injured. Um, Nipple line is T4 dermatome, and then your umbilical, your navel is you're on T10 umbilical, T10. My God, I can't speak today. T10 dermatome, right? So kind of have an idea of where that's located. T4 nipple line, T10 belly button. All right, so muscles in the walls of the blood vessels are cut from the sympathetic nervous system and nerve impulses that cause them to contract. All vessels below the level of spinal cord injury dilate widely. It's massive dilation of your vessels, increasing the size and capacity of the vascular system, causing blood to start pooling. So basically anything below the injury down, you'll have significant dilation. All right, anaphylaxis or anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure after sensitization tends to produce a more severe reaction, right? So we want to make sure that we're treating this stuff appropriately with the anaphylaxis. So you can kind of see all the things that are on here. I'm not going to read through all these up here on the screen so you guys can actually see those. But again, don't be afraid to pull the trigger to give epi. 0.3 milligrams of epi is going to work tremendously for these patients. And it's not going to really hurt them. Even the pediatrics can tolerate epi a lot better than even adults can. Okay. But if you start seeing that urticaria, you start seeing those hives, you start seeing edema or angioedema, which would be like specific swelling of the tongue, cyanosis, obviously really bad, nausea, vomiting, AMS, fainting, dizziness, right? A drop in blood pressure, that those dilated peripheral blood vessels, increased vessel permeabilities. We started seeing the barely palpable pulse, weak pulses. Look for all that stuff as their airway compromise, things like that. If you're starting to see any kinds of signs of that, give them the epi. All right, they're going to need it. Psychogenic shock. A patient in psychogenic shock has had a sudden reaction of the nervous system that produces a temporary generalized vasodilation, resulting in syncope. All right. This can be life-threatening. Causes include irregular heartbeat, brain aneurysm. Not life-threatening would include a receipt or they receive the bad news or experiencing a fear of unpleasant sight, such as blood. People have that they pass out in the dentist's office. It's usually like a psychogenic shock. All right, hypovolemia. Result in adequate amount of fluid volume in the circulatory system. There are hemorrhagic causes and non-hemorrhagic causes. We talked about the vomiting, diarrhea being non versus significant bleeding. Also, severe thermal burns can cause hypovolemia as well. So the progression of shock, the stages of the progression of shock are compensated, decompensated, and when it's progressed too far, it's now irreversible, where there's no way to assess the patient has reached this point. We don't know. So that's why we gotta treat it early, well before the patient transitions into decompensated phase, right? So we look at that progression that's there. So as you can see on here, here's your signs and symptoms of the progression of compensated. Agitation, anxiety, restlessness, feeling of impending doom, weak, rapid, throaty pulse, clammy, pale, cool, moist skin, pallor, so cyanosis about the lips, shallow rapid breathing, nausea, vomiting, cap refill is longer than 2 seconds in infants or children, marked thirst and narrowing pulse pressures. Okay. Did you notice out of all of these things here, hypotension was never mentioned, right? So when you guys are probably in EMT school many years ago, you're probably taught that it's compensated shock and hypotension. That is no longer the case anymore. That was actually false statements, right? Decompensated shock, first thing right here, blood pressure. It's no longer in the compensated shock thing. When you start seeing lowering blood pressures of less than 90 systolic. We're in decompensated shock at this time. Declining mental status, labored or irregular breathing, ashen mottled cyanotic skin, thready or absent peripheral pulses. Why? Because if you look at the rule of thumb based on pre-hospital trauma life support, if a patient has a blood pressure of less than 90, they're not going to have radial pulses in your hypovolemic deals, right? So if you have no radials and all you can feel is a carotid pulse, normally, by rule of thumb, their systolic blood pressure is 60. Okay. Dull eyes, dilated pupils, poor urinary output. Why? Because your kidneys are starting to shut down because they're not getting enough blood to them. So you're going to have poor output. Right? So blood pressure may be the last measurable factor. So I'm just going to try to circle as best I possibly can. I just keep harping on this here because people keep thinking, oh, hypotension, hypotension. It's not. All right. Last measurable factor to change in shock. When a blood pressure is drop in blood pressure is evident, shock is well developed at that point. We miss something if they're already hypotensive, unless you got to the scene and they already were. But if you've had the patient for 20 minutes and you didn't pick up on those compensated shock indicators, then we're not doing something right in the back of the ambulance. We're missing something, right? Particularly true in infants and children. Remember that infants and children can compensate like no tomorrow, better than an adult can, right? So you've got to look for those other indicators that are there to say, there's something not right. When the blood pressure drops in infants and children in shock, they are close to death because they can compensate like this. Here's a child. This is compensation. And then boom, they die, drop quickly. With an adult, we start seeing this. We'll start seeing that decline like that, right? These are kids. These are adults. This is what scares me, right? If I miss something of a sign, and next thing you know, they've dropped so low that you can't get back. Remember that in an infant, okay, we're talking like, maybe 1 year old, they have very minimal volume, right? So they can maintain, but once they've hit that threshold, it drops very quick, where they may only have 500 mLs of blood in their system, where we're carrying 5 to 6 liters of blood in ours for adults, right? Infants usually have about 250 mLs of blood, and that is it. That's it. Also expect shock in a patient that has any one of the following conditions: multiple severe fractures. Remember that your pelvic cavity can hold up to 3 to 4 liters of blood in your pelvic cavity if you have an open book fracture and have severed one of the femoral arteries. Okay. Your femurs can hold roughly 750 to 1,000 milliliters of blood per broken femur. Okay. So think about how much blood can be stored there before you start actually seeing something. Okay. So keep that in the back of your head. Abdominal or chest injuries, spinal injuries, a severe infection like sepsis, major heart attacks, cardiogenics, anaphylaxis as well, that widespread vasodilation from the toxin that's there. So looking at all this, everything we talked about, let's talk about scene size. Obviously, be alert, potential hazards, wear your gloves, mechanism of injury, nature of illness, what happened, what's going on, how long you've been sick for, has there been a motor vehicle accident, was there any entrapment, is there a death in the same patient compartment? Okay, these are things we need to look at when we're coming up to a motor vehicle crash. Patient fell 30 feet from a barn. Look at all the different factors that are there. Look at the mechanism and say, if I were to fall and hit the ground this hard, I would suspect to see these injuries. Motorcycle accident, up and over the handlebars, I suspect certain injuries, right? Obviously, the ejection from the motorcycle, but if it went over the handlebars, most likely pelvic fracture, femur fracture, because that's where it got caught on the handlebars and separated and pulled, right? Look at your motor vehicle accidents. Is it up and over through the windshield, or is it a down and under? If it's a down and under, then you have that significant impact to the knees, which then transfers energy through the femurs into the pelvis, shattering the pelvis or the femoral head, causing internal bleeding. So when you see accidents, picture that force that's been driven and what kind of injuries you suspect to see. What should there be for injuries? They may not be broken, but they should be, right? Those are the injury patterns that I'm suspected to see. Right? Primary assessment. The primary assessment for a patient with suspected shock should include a rapid exam. Remember that rapid trauma assessments should take no more than 60 to 90 seconds. That's why they call it rapid. Rapid head to toe, treat anything life-threatening, get him in the back of the ambulance, then work on your detailed assessment after you treated anything that's life-threatening first, on your rapid, right? Femur fractures, pelvic fractures, pneumothoraxes, airway compromise, things like that. Those are significant bleeding, arterial bleeding. Those are life-threatening injuries. A fractured ankle is not a life-threatening injury. That can be splinted in the back of the ambulance if it's something that's critical for a patient, right? Ulnar radial fractures of the arm are not considered critical, okay? Pelvis, femur, abdominal bleeding, things like that. Those are your critical patients. So a patient identify and manage life-threatening conditions as they are found, determine the priority of the patient, and then transport, right? If you have a priority one patient, call for ALS, call for flight, whatever you need to do, get them to a trauma center. They need surgery, okay? Not a local critical access. They need to be taken to a trauma center, right? Determine the priority of the patient. A patient with a massive hemorrhage may require a tourniquet or direct pressure dressings when a tourniquet is not feasible or available before the airway is opened. You can control airway all day long, but if they bleed out, they're dead. You've got to stop that bleed. Tourniquet, move forward, right? Your ambulance, I mean, you guys should always carry a minimum of 2 tourniquets anyways. Carry them, utilize them, keep them in your first in bag, because it's something that's going to be a quick treatment. If a patient has a life-threatening external bleed, it should be addressed first, even before airway or breathing. The ABCs can be assessed and treated, and treatments for shock are then provided at that point. Provide high flow oxygen to assist perfusion and damaged tissues. Just because it says 98% does not mean that they don't need oxygen because it's a traumatic injury. High flow, non-rebreather, and or if you need to assist with the BVM. ALS with more aggressive shock management as well. Form a general impression. Are they sick or not sick? Determine the need for manual stabilization of the spine and assess patient's level of consciousness. Sir, can you hear me? Are they moaning? Are they speaking? So look at that ABPU scale, right? Alert, verbal, painful, unresponsive, right? I'm not asking you to start asking questions of your AO times 4. This is a quick general impression. Are they awake or are they not? Right? As quickly assess breathing. Are they breathing? Are they breathing rapid, shallow? What does it look like to you? Quick assessment. Circulation, assess the circulatory status, can reveal important clues regarding presence of shock. Feel radial, is it rapid and thready? Are they pale and diaphoretic? The patient's in shock. Don't know what kind yet, but they're in shock. We'll figure it out as we do more of an assessment. Right, check for that distal pulse, right? Check for radials. Do not waste your time. This is me speaking as my own opinion. Don't waste your time on checking a dorsal pedal pulse. It could take you minutes, and if they're already shunting, you're not going to feel it. The best way to assess perfusion status in the lower extremity like that is cap refill, right? Don't spend your time trying to find a popliteal, dorsal pedal, tibial. Don't look for those. We'll do that in your detailed assessment in the back of the ambulance. Look for your cap refill. This is a rapid assessment, right? A rapid pulse suggests compensated shock, right? Determine if it's fast, slow, weak, strong, or altogether absent for your pulses. In a shock or compensated shock, the skin may be cool, clammy, or ashen. If the patient has no pulse and is not breathing, immediately begin CPR, right? Assess for and identify any life-threatening bleeding in trauma patients. Treat immediately if they are found. Quickly assess the skin temperature, condition, color, and then check for cap refill time, right? quick cap refills, very fast, easy to assess. Transport to remember the patient should be treated as a high priority, whether ALS is needed, and which facility to transport to. If they're in shock, they're bleeding somewhere internally, they need surgery, right? If you take them to a critical access, it becomes a pain because they have to be admitted, seen by a physician, and then transport out because you cannot violate EMTALA. Okay. Your best bet is to transport this patient to the trauma center, get ALS or flight. And the only time you don't violate EMTALA, so here's EMTALA for you in a quick rundown. If you transport a patient to a hospital, and once you cross onto hospital property, you cannot divert and go to a different hospital. That's violation of EMTALA. The only time you can use the hospital property and not go inside the ER is if you're using their helipad as a landing zone for transport. Okay. Other than that, you have to bring the patient into the ER once you cross hospital lines, right? So don't violate EMTALA, call med control, and find out what the best option is going to be. Flight may be your best option. If not, you guys are going to Augusta for a trauma center. You guys are going to Aiken anyways. I don't know Aiken very well. Maybe you guys do. Are they a level 1 trauma center or level 2?
They're not a trauma center.
At all?
No. We took a degloving injury to Aiken, and they're like, this needed to go to Augusta. Don't ever bring a trauma like this here again. And you were like, okay.
Fair enough.
Aiken is not a trauma center. Augusta, well, oh, they are? No? Okay. Wellstar, which was Augusta University, is a level 1 trauma center.
Right?
Yeah.
So that's where they need to be. So how far, if you guys respond with Jackson First Alert and you guys get to the scene, motor vehicle accident, patient significant trauma, you guys obviously call for ALS. ALS is not available right away. You have the option to fly or transport to Augusta, right? How far is it to your level 1 trauma center from where you guys are located?
With lights and sirens, maybe 20, 25 minutes.
Okay. That's great responses right there. And where's your ALS going to come from?
From Jackson, it's like 15 minutes to Augusta.
That's not bad at all, right?
Yeah, not bad at all. Yeah.
No. So obviously that you guys are in a great area, but you can get to a level 1 trauma center, right? So where I'm from, it would take an hour to find the closest level 1 or level 2 trauma center was an hour away. So we'd use flight a lot, or go by ground and with paramedics that we treat during the transport. Right. So again, do you need flight? Now, if you had a motor vehicle accident with entrapment, patient's not doing well, they're in shock, and you're saying, well, this is only 15 minutes away, right? 15 minutes of time during transport can be life or death if they need blood products. So call for flight. They can bring that life-saving blood to the scene and start it right away. Right. So think about the resources you have, how long the extrication may take, and how long your transport's going to be, and will flight, even though it's a 15-minute drive, can they bring a life-saving medication like blood products to actually make a difference?
So they can actually do the blood products while somebody's still entrapped, correct?
Absolutely, yes.
What I thought.
Yep, they can start blood while they're still trapped in the vehicle. If the patient needs it, they're going to give it. Right? That's another thing when you do your training stuff also is work with them. You know, one of the things that they're doing right now for Orangeburg 911 is LifeNet has provided blood tubing for them. So they can start saline through blood tubing. So when flight gets there to give blood products, the tubing's already installed and ready to go. All they have to do is spike the bag into the blood and run it. It saves 4 minutes. So again, work with your services in the area for flight and see if that's something that being at the advanced level of your service, can you do that? Can they give it to you and you can start it on a scene? And then when they get there, it's already running. Things to think about. I'm just saying, there's things you can do to speed up the process for these trauma patients. History taking, obviously, after life threats have been managed, we're going to interrogate our patient the best we can, looking at our sample history, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading up to illness or injury, right? We're going to figure out what is going on. Now, if they're unresponsive, look for certain things like ID bracelets, bystanders, family that could be present, and ask these questions that you need. Right. Secondary assessment, your physical exam, repeat the primary assessment, followed by a focus assessment. I look at your primary. Focus is only going to be focused on if the patient is not critical, right? If it's like, let's say, a trip and fall with a knee injury, it'll be focused on the knee, right? So again, is it going to be your detailed or is it going to be your focused? Which way do you want to go? But you got to repeat that primary, looking at those ABCs over and over again, right? Because things can change rapidly. And the one thing I'm going to say, I know this is not strictly just a shock, not just trauma. You've got to get your patients trauma naked. You've got to expose them from head to toe, right? If you miss something, they leave their shirt on, you miss Gray Turner's sign, okay? Which would be like your splenic injuries, things like that, kidney injuries. You see significant bruising on the flanks. That's called Gray Turner's, right? And you missed that because you didn't expose your patient. Or Cullen's sign. Cullen's sign being significant bruising around the umbilicus, could be something pancreatic, could be something internal bleeding, right? Or the patient's complaining of shoulder pain and you didn't expose and they have Kerr's sign because they have a splenic injury now and it's the referred pain going to the shoulder, right? There's different signs that like Murphy's sign, looking for McBurney's point for right lower quadrant pain. The patient has appendicitis. There's a lot of things you can look for. And these patients, by just touching your patient, exposing them and taking a look and seeing what's going on, right? So if your patient's a trauma patient with significant mechanism of injury or multiple injuries, your patient gives you a poor initial general impression. You walk in, they look sick. This is one of those things where we're not going to stay and play. We're going to load and go, right? You found problems in your primary assessment we need to address, right? These are part of your secondary assessments. Your primary, so your patient has a medical problem, but is not responsive, right? Your patient has problems that were not noted in the primary assessment. If the patient goes unresponsive, check out glucose. That could be what caused the injury or the accident to begin with. Check your sugars. The assessment should be performed quickly but thoroughly to ensure that you do not miss any significant or life-threatening problems or delay in needed care, right? Use your monitoring devices. Remember, there are devices so again, take those with a grain of salt, right? Remember, whether your examination is of the entire body or a specific area, if a life-threatening problem is found, treat it immediately and get your vital signs. Remember, it's every 5 or 15, depending on stability of the patient. Reassess the patient, vitals, interventions, chief complaints, ABCs, mental status. Just kind of reassess. Determine what interventions are needed for the patient based on the assessment findings. Focus on supporting your cardiovascular system and treat for shock early and aggressively by providing oxygen and keeping the patient warm. I don't care if it's 95 degrees outside. If they are losing blood, they are getting cold. Cold kills patients. It's part of that triad of death. Hypothermia is one of the three things. Okay. So you got to make sure. So coagulation, hypothermia, hypoxia. Those will kill your patients for trauma. If you have the money, they're not super expensive, but they have those heat pad warming blankets, one-time use, right? They get to like 130 degrees and they can warm a patient up like you wouldn't believe. Good investment to have. If you guys are doing 911 stuff, great investment to have. Keeps the patient warm. Emergency medical care for shock would be an immediate treatment, obviously, as soon as you realize the condition exists, right? Standard precautions, control bleeding, make sure the patient has an open airway, inline stabilization, put on a C-collar, check for breathing and pulse, right? Comfort, calm, and reassure the patient the best you can. We're doing the best we can to help you. Maintain the patient in their supine position. Never allow a patient to eat or drink anything prior to being evaluated by a physician. They need to be NPO because the reason being is that they need surgery. They cannot be eating or drinking anything prior to that, right? If spinal stabilization is indicated, you can use a backboard. Follow your protocols. Backboards in places that I've worked in different states have phased them out. Now we use a scoop, pick them up, put them on the stretcher, take the scoop off. We don't leave patients on boards anymore. It's actually causing more damage than good. but cervical collars is definitely a must. Remember that inadequate ventilation may be a major factor in the development of shock. Right, so always provide oxygen, assist with ventilations, and use airway controlled adjuncts as needed. NPAs, OPAs, right? Obviously, with no gag reflex, things like that. To prevent heat loss, remember blankets under and over the patient. Wrap them like a burrito. Heat blankets, I said, would work tremendously well. Transport the patient and treat additional injuries en route. Consider rendezvous with ALS, or consider air transport. Accurately record the patient's vital signs every 5 minutes throughout the treatment and transport of this patient. For cardiogenic shock, the patient who is in shock as a result of a heart attack simply cannot generate the necessary power to pump blood throughout the circulatory system. Usually patients with cardiogenic shock do not have any injury, but they may be having chest pain. Patients with cardiogenic shock should also receive nitroglycerin. They should not receive nitroglycerin. By definition, they are hypotensive. If the patient's hypotensive or very borderline, and you give nitro and you vasodilate, you're going to bottom their pressures out. Patients that are in cardiogenic shock also have very low preload, therefore you're going to bottom them out very quickly. Signs and symptoms would be nausea, anxiety, cyanosis around the lips, underneath the fingernails, weak, irregular pulses, and then low blood pressure. We're going to place the patient in a position that eases breathing as you give high flow oxygen. So 30 degrees, sitting up, what's comfortable for them, and that's what you're going to put them in. If they have pulmonary edema, sit them up. Last thing you want to do is distribute that fluid throughout the entire lungs. Okay, so sit them up, keep the fluid low if they're in a pulmonary edemic state. Unless they go unresponsive, then you gotta lay them down flat and start providing positive pressure ventilation and make sure ALS is en route. They need to be intubated at that point. All right, for cardiac tamponade, high flow oxygen, surgery is the only definitive treatment. If they have, they need a pericardiocentesis as well. That's a big long needle through the chest into the pericardial sac, and we're going to pull fluid out. All right, so increasing cardiac output should be the priority. We got to make sure we're pushing that fluid out. We increase our cardiac output. Retention pneumo, chest decompression is the answer to this. So again, do not delay transport and waiting for ALS to start going. If your closest ALS is the hospital, then document as such. Remember that your chest runs in a negative pressure system. Therefore, if air is coming out, the lung will collapse. So treat septic shock. The proper treatment of septic shock requires complex hospital management, including administration of antibiotics. Ventilatory support may be necessary. These patients may get intubated really to help control it. Notify a sepsis team if available. A lot of states have gone to septic alerts or sepsis alerts. And what that does is it starts the process of getting fluids out, getting your blood culture tubes ready, lactic tubes, rainbows, all that kind of stuff in the ERs. It helps prep for it. And then they're going to start antibiotics. They look at these different bundles. And that's all part of my sepsis lecture of what they do, like what we can do in the field recognition, and then the process inside the hospital with that. All right, so treatment should be for neurogenic, obtaining and maintaining proper airway, spinal mobilization, conserving body heat, assisting inadequate breathing as needed, ensuring the most effective circulation possible, and then transport to facility capable of managing spinal injuries. Anaphylaxis, we've hit this a little bit already. Again, if you notice anaphylaxis, obviously the patient with anaphylaxis requires immediate treatment. So ventilations, obviously high flow oxygen, things that are needed with that. Epinephrine. If they're in anaphylactic shock, they need epi. Epi not only vasoconstricts, it also brings up blood pressure. It's a sympathomimetic medication, right? That fight or flight deal. So things start increasing. Heart rate goes up, blood pressure goes up. You start constricting more, so that way you're not vasodilating from the reaction or whatever you got in contact with. We need to make sure we're getting epi on board. And you may have to get a second, third, fourth, fifth dose, depending how often you need to give it. Usually it's like every 5 minutes, depending on patient stability. Psychogenic, if an uncomplicated case of fainting, once patient collapses, becomes supine, circulation to the brain is restored, and they're normal and they're functioning fine. but it can worsen other types of shock. So if a patient fell as a result of psychogenic shock, check for injury, especially in the older patient, because they could have something else going, like broke something like a femur. Now they're bleeding into their femur, they become hypovolemic. So just kind of keep that in mind when you're doing your assessment. If they fell, just do a quick rapid, find out what's going on, and then go from there. The patient reports being unable to walk after a fall. Thought to be related to psychogenic shock. You should suspect another problem, such as a head injury. Right, and I will do a whole lecture on head trauma coming up at some point. So if we're not going to hit this pretty hard. Transport the patient promptly, and all patients with loss of consciousness should be transported to the ED for evaluation, even if they appear normal once you have arrived. A big one with that, the meningeal artery, you could have an epidural bleed. So the middle meningeal artery, I think like MMA, like kickboxing, things like that, they kick to the head. Normally they have like an epidural bleed. Those can have a period of lucidness, but then they become alert oriented and they're perfectly fine, even though they're actually bleeding in their brain. So things to think about. Treating hypovolemia or hypovolemic shock, obviously control bleeding. Handle gentle and keep them warm. Remember, they've lost fluids, right? There's a bleed, tourniquet it. In places you're allowed to put a tourniquet, right? If not, direct pressure. Secure and maintain an airway. Provide respiratory support, including supplemental oxygen and ventilation as needed. Transport as rapidly as possible. Remember to still drive safe. Get them to where they need to be. Call for ALS because they can start fluids. If it's a traumatic hypovolemic shock, then blood products may be a better option. So talk to your critical care teams and things like that in Augusta. Maybe they can intercept with you and bring blood products by ground. The earlier you get blood products on board, the better the patient can be. So again, have those conversations with those teams that do flight and ground transport. Maybe they can help you out. Aiken County is not doing blood products, are they? That I don't know. I'm not sure if you guys know that or not. All right, moving forward. So treating shock in the older patients generally have more serious complications than younger patients. Many older patients that take numerous medications that can mask or mimic signs of shock. Okay, what medication can lower heart rate and mask the sign of shock that patients take? It can be treated for blood pressure and heart rate control. So think of beta blockers, anything ending in OLOL, like metoprolol. Patients that are on beta blockers will drop heart rate and drop blood pressure. I say to control it. So a patient that's elderly, that's on a beta blocker, that's in shock, you may not have that tachycardia present. So you have to get your sample history. You've got to ask those specific questions. All right. Go back one more here. All right. So with that being said, we're going to go into some review questions, kind of make sure you guys got everything that's there. And then we'll sign the roster. I'll stop the recording, do any more question and answer stuff, and then we'll call it a night. All right. So you guys can put it in the chat box, unmute. I just want to see you guys interacting with this, show that you guys paid attention. So the term shock is most accurately defined as A, B, C, or D. Grant, I know you guys are all in a group, so you can put it in the chat or whatever you want to do. It doesn't matter. You guys don't have to do it. You guys can just do it together as a group. But A, B, C, or D.
Would you be able to read it out? It's on my phone. They can't see
That's
it.
right. You guys are on your phone. Sure, I can do that. So the term shock is most accurately defined as A is a decreased supply of oxygen to the brain. B, cardiovascular collapse leading to inadequate perfusion. C is decreased circulation of blood within the venous circulation, and D is decreased function of the respiratory system, leading to hypoxia.
Where's the chat box?
You're on your phone too, Rachel, right?
Yeah, yeah.
It might be a separate screen that has it.
Oh, it is. Never mind. I found it. All right, let me just go back. I'm just gonna say, I'll just text it to you. B.
So
B.
remember that shock has inadequate perfusion, right?
Yeah.
So basically, the answer would be B. Cardiovascular collapse, right? Inadequate perfusion. So your cardiovascular system is collapsing, which means that it could be vasodilation, and then or cardiogenic shock, heart pump failure, vasculature failure, or fluid loss, causing the cardiovascular system to collapse, leading to inadequate perfusion. All right. Anaphylactic shock is typically associated with urticaria. What was that?
So it was B then?
Yes.
Yes, it was B.
Okay, good.
Yep. Anaphylactic shock is typically associated with urticaria, which is a rash, bradycardia, localized welts, or a severe headache.
No.
A.
Hey.
Urticaria.
Nice.
Number 3, signs of compensated shock include all the following except restlessness, anxiety, pale, clammy, cool skin, the feeling of impending doom, or weak or absent peripheral pulses. Compensated shock.
E.
D. Yeah, we
D.
Definitely sounds a little excessive.
Yeah, right.
We're not compensating anymore.
Yeah.
The answer is definitely D on that one. All right. Ooh. When treating a trauma patient who is in shock, the lowest priority should be given to spinal protection, thermal management, splinting fractures, or notifying the hospital.
C.
C? Yep, C it is. Splinting.
I want to joke and say D, but
All right. Who
notifying
cares
the
about the hospital? Surprise. That's the worst thing ever coming into ER. Surprise, patient's unresponsive.
Yep.
They would not be happy at all.
We got a bad one.
Oops. Potential causes of cardiogenic shock include all of the following except inadequate heart function, disease of muscle tissue, severe bacterial infection, impaired electrical system. Remember, it's a cardiogenic shock. All the following except.
What was that again?
B. I think it's
B. I think
it's
B.
Yeah,
unless
C.
muscle would be the.
Your bacterial infection is not going to put someone in cardiogenic shock. That'd be your sepsis.
yeah.
Yep.
I'm thinking of that bacterial infection of the sac around the heart.
Yeah, that's your pericardial. That's your pericardial tamponade.
Oh, yes. Okay.
Right, pericardial tamponade being blood. Usually, it's blood filled around the sac from a traumatic event.
Thank you. Okay.
Yep. 5 is that's not right. We're on to 6. Sure. So a 60-year-old woman presents with a blood pressure of 80/60, a pulse rate of 110, mottled skin, a temperature of 103.9. She is most likely experiencing septic shock, neurogenic shock, profound heart failure, or a severe viral infection.
A.
Everybody's going with A?
A.
Right?
Sepsis alert.
Everyone's scared for sepsis right
Sepsis
now.
alert,
So yeah.
So remember, I mentioned before, hypotension,
Yep.
right? And heart rate greater than 90, and a temp of greater than 114, I mean.
Boom.
Yep. So she's definitely septic shock, because that shock, part of that is that hypotension, right? Now,
Yeah.
looking at the breakdown I did, that would be severe sepsis. you still got to treat it with fluids. If there was fluids were treated with this here, and then there was no change in blood pressure, now they're in septic shock.
Right.
Brett nor myself will ever overlook septic shock.
Please don't. A patient with neurogenic shock would least likely to present with tachypnea, hypotension, tachycardia, altered mentation. Neurogenic shock. That's that spinal. I think I heard C, right?
Least likely to present with.
Yeah, because it would be bradycardia, right?
Yes, right, exactly. That's
So
that That's that neurogenic.
But Crystal was adamantly disagree. Okay.
So a 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. Heart rate is 120. Respiratory rate of 30. You should treat this patient for a lacerated liver, a ruptured spleen, respiratory failure, or hypovolemic shock.
Hypovolemic shock.
Right. This is a shock lecture, right?
Yeah.
So,
Yeah.
now, a lacerated liver can cause hypovolemic shock, but we're not going to treat the liver.
Yeah.
All right, number 9. So yeah, 33-year-old woman presents with generalized rash, facial swelling, hypotension approximately 10 minutes after being stung by a hornet. Her blood pressure is 70/50. Her heart rate is 120. In addition to high flow oxygen, this patient is in most immediate need of epinephrine, right? Rapid transport, antihistamine, or IV fluids. I'll go with epi. Benadryl does help, but it's not going to fix what's currently going on.
Right.
And the last one, all the following are potential causes of impaired tissue perfusion except increased number of red blood cells, pump failure, low fluid volume, poor vessel function.
A.
Yeah.
A.
It is. All right, I will leave this up for you guys here. Please make sure that you scan this and fill out the roster. If you're on your phone,
Hang on.
I think there's a way you can do it, or you can screenshot it somehow and do it.
Yeah. I think that's how I'd done it before. Is a screenshot.
Yeah, go ahead and fill that out, and then once those are done, I will put them in your national registry as long as it's functioning appropriately.
Is it on speaker?
Yes.
Hey, this is Crystal. Would you go to sneeze? No. I have some of